myself. My name is Namira, and I am the founder of E for Endometriosis. It is an ACRA-registered establishment for endometriosis awareness. I am holding a full-time job in the education sector and has been passionately advocating on endometriosis since 2012. And in 2017, I set up the Singapore Endometriosis Support Group Facebook account alongside Bharti and Dr. Mali because we feel the awareness needed a platform that is accessible for many of us who is affected with endometriosis, be it caregivers or patients, to interact and comfort one another. I myself am battling stage 4 endometriosis, adenomyosis, and infertility issues. I went through a total of 4 surgeries. I was admitted to IMH for depression. Most part of it is due to endometriosis. And I have been sharing my stories because I feel a sense of responsibility towards the community here in Singapore. I believe that for a change to happen, it must start somewhere. And I decided that instead of wanting and wishing on what could be and what should be, I'll just make it happen. So here I am after 8 years of advocating. I am finally officializing the website today. I am grateful to cross paths with Dr. Mali, who is an accredited ONG specialist in this advocacy journey. Dr. Mali provides services in endometriosis and advanced laparoscopic surgery. She is experienced in surgery for complex gynaecological conditions and deep infiltrating endometriosis. Her main interests are endometriosis, chronic pelvic pain, advanced sonography in endometriosis, single port laparoscopy, and nerve sparing surgery for endometriosis. All right, disclaimers before we begin and some ground rules. Hope that you can adhere to this. Number 1, do note that online conferences cannot fully replace face-to-face consultations due to various limitations. It is to be taken on general point of view, so please follow up with thorough examinations from healthcare professionals. Number 2, do take note that this session is being recorded, but I'm still trying to figure out how to. So if any one of you know how, please, you can just voice out. Appreciate that. Thank you. And will be used for our endometriosis awareness campaigns. We do encourage you to switch on your video so we can see your beautiful face and have a mutual interaction. Right. Number 3, in order to ensure a safe and comfortable session to learn and empower, kindly be respectful towards each other. So converse with care. Should anyone decline to answer a question, respect their boundaries. Number 4, kindly put yourself on mute to prevent background noise and interruptions. Participants are encouraged to unmute themselves only when they are posing questions. They are to mute themselves again after that. So try to be in a quiet place during the session to minimize disruption. And lastly, number 5, at the end of the session, we will be taking a group photo together to commemorate this historical moment with the E for endometriosis signature E sign. All right, without further ado, I shall pass over to Dr. Mali. You may proceed. Thank you.
Thank you very much, Mira, for the kind introduction. Over the years, we have been working with Mira in promoting awareness for endometriosis. I'm very glad that we have everybody on board to promote the awareness of this debilitating conditions. I'll give a short talk today regarding the diagnosis, introduction, and general management of this condition. Then we'll follow by Q&A if anybody have any questions. So let me share my screen. Can you see? Okay, so today we're gonna talk a bit about truths and myths in management of endometriosis. So, I mean, this is a very common condition, but yet it is fully recognized, and even among the general practitioner, among the specialists, there's quite a significant delay in diagnosis of endometriosis, and the management really varies, depends on which doctor you encounter. So this is very typical stories of patients with endometriosis. So at 22 years old, she's having a dysmenorrhea, and then she was started on contraceptive pills with some improvement. At the age of 29, the pain is no longer responsive to contraceptive pills. Then she had a laparoscopic excisional surgeries and was diagnosed as stage 3 endometriosis. And she was started on COC, which is contraceptive pills. Then at the age of 44, she started to have more pain with dysmenorrhea, dyspareunia, which is pain during sexual intercourse, and also have irregular bleeding. Then she had repeated surgeries and also excisional endometriosis. Then at the age of 50s, the pain come back and got worsened.
我不懂会有没有来，一来的肚子痛拉肚子要进医院。
In the end, she has to go for
1个礼拜哦。昨天我就问他你可以来吗？他讲我应该 OK。
So this is a very typical stories, and this is quite common when we're running endometriosis clinic, where we see patients underwent multiple surgeries and the pain still persists. So what is the problems of our diagnosis, and what is the problems in the management of this condition? So today my talk will basically cover the symptoms and signs and how to diagnose it, and when and how to do surgery, and how to manage this condition in a lifelong time. So we all know that it is very common. It affects about 10% of women of reproductive age, and 30 to 40% of women with suffered problems are diagnosed as endometriosis. And for those who have pain on menstruation, 40 to 60% of them actually were diagnosed as endometriosis. But endometriosis does not equal cyst. Quite commonly, we know that, okay, patient going for surgeries for endometriotic cyst, but endometriosis is not only about the cyst. It's actually more invasive and more extensive than people can ever think. So far, the world literature has reported endometriosis in almost all of the body organs, including lungs, nose, brains, or knees. So it's very debilitating condition which behaves like a cancer cells, which may potentially spread to all the organs that you can imagine, and then again causing pain and also affect fertilities. So I'm going to talk a bit more about these more severe types of endometriosis called deep infiltrating endometriosis. So on the picture on the right side shows anatomy of the female pelvis on the lateral view. On the left is the bladder, and then in the center is the uterus and the cervix, and the bowels is at the back. So, so the deep infiltrating endometriosis basically can quite commonly invade into the surrounding organs, including vagina, uterus, the ligaments supporting uterus, bowels, bladder, ureters, etc. And it's not rare. So in patients who are diagnosed as endometriosis, we actually found that this severe type of endometriosis affecting up to 30 to 40% of patients. The definition of DIE is presence of this nodule penetrating more than 5 millimeters under the peritoneal surface. So the typical site of deep endometriosis is at the ligament, rectal vaginal septum, which is the tissue in between the bowels and vagina, and also vaginal wall, bowels, and ureter and bladder, etc. So this is the more common type of deep endometriosis that we see during surgeries. So for this condition, it is a benign disease, but it is affecting very, very young patients. And the surgeries for this type is different from endometriotic cyst because we are operating very closely to all these important organs like ureters, bowels, and kidneys. Ureter, bowels, and bladders. So it does carries a greater risk for all these organs. And at the same time, when trying to remove this condition, we have to preserve the organ functions as well. So different from cancer treatment, where the aim was for radical removal of all the disease. For deep infiltrating endometriosis, the aim, apart from radical removal of all the disease, we also have to take into consideration of patients' fertilities and the function of the organs. So treatment usually is tailored to each individual according to their different clinical presentations, stages of the disease, personal expectations, and also risk of recurrence. So how to diagnose endometriosis? So it is very common conditions, and yet people or all things, very, very common in Asian cultures, people all think that it is normal to have menstrual pain. Especially for young girls, their mommy or grandparents' generation would tell them it is normal to have pain, and once you give birth, the pain will go away. That's why, especially in the Asian background, there is a quite significant delay in diagnosing of endometriosis. The average of delay is 6 to 12 years. And the delayed treatment is also associated with reduced quality of life, with depression, inability to work, sexual dysfunctions, missed opportunities for motherhood. So because delayed treatment and so cause the progression of the disease, so quite often by the time patients come to seek specialist treatment, their fertilities may have already been affected. And in diagnosing, apart from the symptoms, the doctors would also do a very detailed pelvic examinations, including examine the uterus, ovaries, and also need to do a bowel examinations just to feel whether there is any endometriosis invading into all these organs. So usually for a doctor won't immediately jump to imagings, because this part of the digital examinations does provide very valuable information in determining the extent of the condition. So the most common symptoms that we're talking about, of course, painful period, but of course the other symptoms, which can also be very highly indicative of endometriosis, including dyspareunia, pain during sexual intercourse. Chronic pelvic pain means that the pain may not be related to menstrual cycles. Bowel upset, similar as IBS symptoms, diarrhea, constipation, tenesmus, which means the urgency of the feelings of urgency to go to toilet to empty the bowels. Dyschezia means the pain on passing motion. These are actually very common for patients with deep infiltrating endometriosis. And quite often we see patients have all these symptoms, but they went to other subspecialties to rule out irritable bowel symptoms, but in the end found to have endometriosis. And of course, subfertility is also one of the very common problems for endometriosis, and also ovarian mass and dysuria. So interestingly, you can find that for endometriotic mass, so the cyst only account for about 20% of patients who have endometriosis. About 80% of endometriosis patients does not have a cyst. So if we're only looking at the ovarian cyst, we'll miss about 80% of patients who have endometriosis. And on the picture on the right lower side, you can see that the common site of endometriosis, not only within the pelvis, it can also go to rare cases like brain, spine, lungs. And in our practice, we also seen endometriosis going to the major vessels, causing blood clots in the lower limb. And also we have seen cases which are obstructing both sides of the ureter, causing loss of functions of kidney functions. So all these are very severe types of endometriosis. So how to diagnose with imagings? You may see some doctors may jump straight to MRI for diagnosing, which is a bit overdue, because ultrasound itself is a very good imaging modality for diagnosing endometriosis, not only on the cyst itself, but also on the pelvic organs like bowels, ureters, and bladder. So on the right lower set, you can see that there's cervix at the back, the bowels, and this is a normal ultrasound scan. A normal ultrasound scan where you can see very clear and very normal bowel walls through the ultrasound scan. So when we're doing endometriosis mapping scan, so apart from assessing uterus, ovaries, as I mentioned, we also need to check bladder and also ureters, which is the tubes that connecting bladder and kidney. We also need to check vagina and also check the bowels. So starting from it's still true transvaginal ultrasound scan, but true transvaginal ultrasound scan we can also assess the bowels all the way up to sigmoid colons. So this gives a very detailed view of about 10 to 15 centimeters of the bowel, to see whether there's any endometriosis invading into the bowels. So especially for surgeon himself, ultrasound scan can give the surgeons a very clear view before they go in for surgeries, and it will be helpful in when doctors are trying to explain to you the extent of this condition, so that we'll get patients ready for the complexity of the surgeries. Endometriosis, of course, is very useful. It can see small diseases that may not be detected under the scan. Usually, currently in our center, we don't use it as the first. So we're talking about management. So quite often I hear patients asking similar questions. So I have a cyst, do I need surgery? And what kind of medicine I have a cyst, my gynae recommended surgery. What shall I do? I have a previous now the cyst is back, and my gynae tell me to go for yet another surgery. What shall I do? And I'm difficulty to get pregnant, and my gynae found that I have endometriosis. And why does that happen so persistent? The hysterectomy. I have adenomyosis. My gynae told me to go for hysterectomy, but I still want a baby. So all these are dilemma and difficult questions. And so before we answer such questions, we need to have a detailed assessment of the patients. And usually, I will explain the objective of treatment of endometriosis, of course, is pain reduction in order to improve quality of life, and again, to prevent recurrence of this condition. And when we're doing surgeries, we need to be radical, means that we need to achieve a complete removal of all the endometriosis disease in one surgeries. But at the same time, we need to avoid destroying the organ functions and and also to protect or improve patients' fertilities. These are the main objective of treatment for endometriosis. So when to do surgery? In older days, doctors believe that, okay, if I found a cyst, I must go for surgery, which is the concept has changed over the past few years, because especially for younger patients with endometriotic cyst, if they're still having fertility wishes, and if the patient doesn't have any other deep infiltrating endometriosis, medical treatment can give a very good suppression for this kind of a small cyst, and hopefully with medications, they can control the size of the cyst until they are ready for conceive. Then if they find difficulty getting pregnant, by then will be one of the indications for surgeries. But again, if they can manage to get pregnant with the cyst, usually fertilities will become on priority over the treatment for surgeries actually. And in older days, we also mentioned that diagnostic laparoscopy is the golden standard when diagnosing endometriosis, but not all patients requires a laparoscopy just for the purpose of diagnosis. So with a good history, with a good physical examinations and with good endometriosis mapping scan, doctors can be very confident in diagnosing endometriosis without putting patients under the scope surgeries. So the surgery will usually more required, let's say if the patient doesn't respond to hormone treatment, or if there's signs that the endometriosis have invaded to surrounding organs, like deeply invaded the bowels or affecting the ureter, affecting kidney functions, or if the cyst doesn't respond to medical treatment, in which still have a significant size after hormonal treatment, or if the pain doesn't respond to treatment, hormone treatment, or fertility. Infertility is also one of the indications to do surgery. Other than that, for very mild endometriosis with just an isolated cyst, usually we don't suggest for surgeries for young patients, because we know that surgery itself, although it removes the cyst, but also may affect the ovarian reserve, in which case may also affect patients' future fertilities. So for mild endometriosis, so in asymptomatic symptoms, they usually do not go for laparoscopic surgeries just for the diagnosis purpose. So we usually scan to diagnose. And for surgery should consider patient's age, pain, future fertility treatment such as IVF. This to surgeries. It does not mean okay, I see a cyst on the ultrasound, go for surgeries. If the patient is young, start with rather than surgeries immediately. And if surgery,
sorry, Dr. Mali. Sorry, Dr. Mali. Can I just pause you for a while? Okay, everyone else, can you just mute yourself, because it's disrupting the session. So please put yourself on mute so that we are able to hear what Dr. Mali is conversing about. Thank you very much. Okay, Dr. Mali, you can proceed.
Okay, thanks, Vera. Yeah, so like I mentioned, the cyst does not equal to surgery. So if you have a cyst, it's better for the doctors to examine properly and also to see whether there's any other endometriosis. If the other organ is not involved, for young patients, if not much of a pain, we can actually monitor or use medications to shrink until they're ready to get pregnant. Then we check the situation. How about deep endometriosis? So usually surgical risk. So by the time the patient develops deep endometriosis, quite often patient would have quite severe pain. So surgical resection improve pain and quality of life. Especially for bowel endometriosis, when we see bowel endometriosis on ultrasound scan, we will suggest for surgeries for excisional of the bowel endometriosis. So there's different ways of doing surgeries for bowels, including just shave of these nodules. But again, if the nodule is very deep and very invasive, some patients may even require spa resections for bowel endometriosis. But again, if patient doesn't have any symptoms or reaching the age of menopause, observation alone may be an option. So we can also giving medical hormonal therapies to consider for releasing of mild pain. So regarding the endometriosis surgeries, there's many different types. Laparoscopic or robotic surgeries is always preferred over open surgery. The rationale is that for open surgeries, we can imagine, okay, the surgeon's eye cannot go very close or very deep into the pelvis. So the vision and exposure is very limited. Whereas for keyhole surgeries or robotic surgeries, the camera can go to very, very deeply into the pelvis and can also have a magnified view of the piece itself. So you can see that there's higher complete removal of all the defects. There's always debate about excisional surgery versus ablation. Many years now, we all know that ablation is so when endometriosis, it's important to do a complete excision rather than just burning the surface of the disease, because by ablation.
Hi, sorry, can someone please mute your phone? I cannot hear properly.
Hello, can you? Yeah. So for ablation surgeries, usually it doesn't fix the pain at all, and there's very high chance that disease may grow back again. So, and also when we're talking about excisional surgery, we always have to aim for complete removal of the disease rather than just partial excision, because leaving a disease inside again would causing recurrence of the pain and regrowth of all the disease. And the first surgeries is always the most important. So whenever we're planning for surgeries, we need to have the best timing to do the surgery, because we don't want to keep coming back for repeated surgeries. And again, when we do the surgeries, we must aim for complete removal so that there's less chance of recurrence and there's maximum improvement of the pain symptoms, and it's good for patients' fertility. So the first surgery is always the most important. So there's a comparison between laparoscopic and open surgery. So we can see that the top right corner is the laparoscopic surgeries where we can really go very, very close to the organ itself. And also we can see very, very clearly, even very, very fine fibers we can see. Whereas you can see the open surgeries, because the surgeon's eye is at least 50 centimeters away from the patients. So there's the view for identifying this is very, very limited. And with laparoscopy surgeries, we can have also a different imaging modalities. So we can use 4D or 3Ds for better visualization. So the video on the left side also is a special kind of imaging, which is a narrowband imaging. It helps to highlight the endometriotic nodule. So there's a comparison. You can see under the narrowband imaging, those which appears to be normal peritoneum, actually the disease would highlight under these narrowband imaging modalities. So that is the advantage of doing laparoscopic surgeries, where we have different high technologies and also can have a much clearer view of the disease. So if we can see clearly, then we can achieve a better excision or complete excision of the disease. So this is a comparison between ablation and excision. I like this photo. It's a very nice illustration between to illustrate the difference between ablation and excision. It's like cutting off the grass. So if we're just burning the top, the root is not removed, well, there's still a very high chance of recurrence after the surgery, and it won't be helpful with the pain management. So if we're aiming for surgeries, we need to cut out all the endometriotic lesions, especially the roots of this lesion. Then this can achieve a better outcome and a better pain relief of this patient. But again, for excisional surgeries, not everybody can perform excisional surgeries, because it is high risky and it's often involving doing surgeries closer to the organs like bowels, ureters, and all these organs. And the surgeries is usually more invasive. So in order to find, patients usually need to find a good excisional surgeons, which are specialized in endometriosis surgery to do this to do excisional surgeries. And usually for excisional surgeries, the recovery time is longer, because we're doing a very extensive surgeries to try to remove all disease. So the post-op recovery time is expected to be slightly longer than ablation surgeries. So the objective of the surgeries, radical means to achieve complete removal of the disease. Conservative towards functions, meaning that we need to protect the fertilities, and also we need to protect the surrounding organ functions like bowels, bladder, or sexual functions. Especially when we're doing excisional surgeries, quite often we're operating closer to the nerves that is innervating all these organs. So right now we are doing nerve sparing surgeries, also aim to improve the organ functions. And again, by doing this, we can reduce the recurrence rate of the endometriosis. So how radical can we be? So this is the few cases that we did before, including there are cases going to the major vessels that we have to excise the nodule along the major vessels. And then the picture in the middle shows that this is a patient with very bad ureter endometriosis, which caused the ballooning of the loss of the both kidney functions. So we have to cut up the ureter and do a reimplant. And also the picture on the right also shows that it's the bowel endometriosis, where we have to remove part of the bowels in order to achieve complete removal of the disease. So all these surgeries are very high risky because there's very high chance of injury to these organs, and also even when we connect the healthy part of the organs together, there is also a risk of leaking. So when doing this kind of surgery, is usually done by a few teams together, including the gynecology team, or sometimes need the urology team, and very often we do need the colorectal team if we need the bowel resections. So find a team that is specialized and experienced in treating endometriosis is very, very important. So conservative towards functions, as mentioned, is usually conserve the nerves that is innervating all these organs, so that the bowel functions or the bladder functions or sexual functions would not be affected after this kind of surgeries. And also at the same time, we have to protect fertilities, because when we're removing the ovarian cyst, unavoidably there will be some follicles, some ovarian tissues which will be removed together. That's why after repeated surgeries for endometriotic cysts, there's usually a reduction of ovarian reserve. So when surgeons performing this kind of surgeries, especially when removing the cyst, there are techniques to protect ovarian reserve, and also usually we don't use any energy to burn on the ovaries. So usually after the cyst was removed, we need to use suture rather than any kind of burning, so that it can minimize the damage to the ovaries. Hysterectomy does not treat endometriosis. We do see many cases where, okay, patients have pain, doctor did the hysterectomy, and after that, the pain still persists. Why? Because from the talk just now, we know that the endometriosis does not only present in the uterus or present in the ovaries. There are other organs that may be affected. So if we only do a hysterectomy, but leave all the other disease alone, still in the pelvis, so predictably, the pain would not be resolved even after hysterectomy. So before the surgeries, so surgeons have to assess very, very carefully in regards of the extent of endometriosis. So if there is endometriosis outside of the uterus, by performing a hysterectomy, it would not solve these problems. So finding the right doctor is very, very important. So there's a few questions we find it's quite useful when you're trying to look for the right doctors that you can discuss with the gynae. So how does the doctor treat endometriosis patient? Is it by excising the disease or by suppressing with drugs? And does this doctor believe in complete excision of all endometriosis? And when a doctor performs excisional surgeries, does she remove all abnormal peritoneum, or what he thinks is just endo? Or can the doctor operate laparoscopically? Does the doctor send all the tissues for pathological evaluation or confirmation? And how many cases does this doctor's, especially excisional surgeries, does this doctor perform in the last 6 months? If the doctor finds invasive disease involving bladder, bowel, ureter, how does she proceed? Basically, you also need to see, apart from gynae, does he have a team that work with her does he have a team that works with her in treatment of all these deep infiltrating endometriosis? And in the end, does this doctor provide patient with a complete record, including the operative report, photos, pathology reports, and etc.? After these kind of surgeries, I always tell my patients surgery is only half of the treatment for endometriosis, even if the surgery is complete, because after the surgery, because we know that endometriosis is a hormone-dependent condition. So even if we remove all the disease with female estrogens, the estrogen will still stimulate new endometriosis from coming back. So we can see from all the research data that the recurrence rate for endometriosis can be 30 to 50% after 2 to 5 years, especially in young patients. Why? Because it is the hormone-dependent disease. So that's why it is very important to use hormone suppression after surgeries. So the most common hormone that we use will be progestogens, which commonly in clinic will be Dynogest or Depo-Provera injections, or some doctors may suggest for Implanon Mirena insertion. Hormone contraceptive, like oral contraceptive pills, is more of a no longer the first line for suppression of endometriosis, because we know that contraceptive pills have estrogen inside, and the estrogen inside these pills may potentially stimulate or disguise the treatment, the symptoms of endometriosis. GnRH agonist is a very strong injections that we don't usually use as a first line, but again, in certain situations, we do use it temporarily to suppress, especially before patients go for IVF or immediately after surgeries. We can give one dose which lasts for 3 months for a quick suppression of hormones. So we can see that with or without hormone suppressions, the recurrence rate is significantly different. So with a very good hormonal suppression after the surgery, the recurrence can be less than 10%. But if we're not giving any hormonal suppression after surgeries, the recurrence can be up to 50 to 60%. Yeah, so there's many different hormones that we can consider. Of course, there are side effects of these hormones. Very often we see on the Facebook, I can see on the Facebook group that many patients are very worried about the side effects of hormones. It is understandable. It is not, these hormones does have side effects. For example, weight gain, irregular bleeding, or effect on the bones. So, but when we're balancing the risk of recurrence for the endometriosis, we still think that although all these medications have side effects, it is much the risk of taking the benefits of taking hormonal medications outweighs of the side effects of these medications. And for the side effect of this medication, we do have method of trying to minimize the side effects as much as possible. So regarding the hormonal treatment, usually I would suggest my patient to take, as long as they are not planning for conceive, usually it's a lifelong treatment. We treat endometriosis as per chronic conditions like diabetes and hypertension until menopause. So take-home message for this talk, I hope everyone can learn from this talk that laparoscopy should not only be used purely for diagnosis. And when diagnosing, ultrasound mapping is over the MRI and surgeries for diagnosis. And cyst does not equal surgeries. Don't jump into surgery immediately if you find a cyst on the ovaries. There are other ways of treating it. And when we're doing surgeries, always aim for a complete excisional surgeries rather than ablation surgeries. And hysterectomy does not cure endometriosis. And first surgery is always the most important. So find the right doctors, find the right team if you're planning for surgeries for endometriosis. So with this, I will end my talk. So I will open up the room for any questions. Thank you very much. Any questions?
Everyone, any questions? You can unmute yourself or you can type it out in the chat. Any questions? Oh, I can see someone typing.
Or can type.
Hi, Namira. This is Xiaowei here. Hello, can you hear me?
Yes, I can hear you. Hello.
Hi. Thanks, Dr. Mali, for the sharing. That's very helpful
So there's
information
one
for us.
question: will endometriosis always linked with adenomyosis? Not necessarily. So it's really depends. Adenomyosis is one kind of endometriosis. So in the talk, we also mentioned endometriosis can invade into many different organs. So if the endometriosis are present in the uterus, it is called adenomyosis. But endometriosis outside of the uterus may not necessarily link to adenomyosis. So second question is, I would like to ask why cancer markers are used in diagnosis like CA199 and CA125. Is it necessary? It's a very, very good question. CA1, so all these markers are kind of like to see how much of a peritoneal cavity are involved. So for young patient, if we find, okay, on the ultrasound scan is very confirmed to be endometriosis, usually I don't use CA125 as a marker because we know that it is not very sensitive. So even if it is high, there are many conditions can cause CA125 to be high. For example, fibroid, pregnancy, or even different part of the menstrual cycles can also cause elevation of CA125. So we don't use as a diagnosis marker for endometriosis. So more importantly, it is the ultrasound scan, face-to-face examinations. One thing I would need to, usually I do for young patients actually is anti-mullerian hormones, because we need to know patients' ovarian reserve functions before deciding whether to do surgeries or not. So the answer is the answer to this question is no, it's not necessary all the times. Third question is, what are the chances of pregnancy and endometriosis? If IVF, are chances better? So yes, of course, there are chances for pregnancy with endometriosis. But for patients with endometriosis, there are about 40% who may have difficulty in trying to get pregnant. So that is 60% of patients do get pregnant with endometriosis. But if you have difficulty in getting pregnancy, we need to quickly work out what is the reason that cannot get pregnant. Is it because of male factor, or is it because female factors? Female factors, we need to consider whether it's a hormonal problems, or whether it's a ovarian problems, or whether it is a tubal factors, which means whether the tubes are blocked or not, or whether there is any uterus factors that is affecting the pregnancy. And then depend on what is the reason for fertilities, then the treatment will be different as well. If endometriosis is the only factor that is causing subfertility, for example, let's say if both tubes are blocked by endometriosis, or there's very low ovarian reserve or quite severe adenomyosis, yes, I would say that IVF would give a higher chance of conceive. Are there ways to monitor if endo has infiltrated other organs besides laparoscopy? So very good question. So if the endometriosis has invaded into important organs, so dependent on the depth of how severe it has invaded, and also depends on patient's age. Monitoring wise, let's say if the invasion is very superficial, or the patient doesn't have much pain, and also on ultrasound scan, the depth of invasion is superficial, and if the patient is reaching menopause, yes, we can choose to monitor by ultrasound scan, by physical examinations. But for younger patients who are not reaching menopause, and if we know that endometriosis has invaded into other important organs, usually the suggestion will be for laparoscopic excision, because this kind of deep infiltrated endometriosis doesn't respond to hormone treatment that well as well. Is there any food to avoid to prevent cysts from growing bigger? Usually, there's no specific food triggers to increase the size of the cyst. We know there are certain foods may have phytoestrogen, so we'll advise patients to avoid consuming large amounts of food that contains phytoestrogen, like for example soybeans. But you really have to consume a large amount in order to achieve this purpose. So if just normal amounts, then shouldn't affect the growing of the cyst. And there are certain foods which may trigger certain bowel discomfort, because for quite often, let's say if the bowel is affected by endometriosis, patients may have certain sensitivity to food. So there are evidence showing that by avoiding certain gluten-free diets helps to manage the pain. Yes, so the next question is, gluten-free diet is really helpful for patients with endometriosis? Yes and no. Usually, let's say if the patients have bowel endometriosis or bowel is affected by severe adhesions, by taking gluten-free diets, it helps with the pain. But for other types of endometriosis, it usually is not very helpful. So what is your view on dietary changes like cutting dairy, high estrogen food to help manage pain with endometriosis? These are important if, let's say, so usually, let's say if the patients have certain food triggers for her pain, we can do a food diary to see specifically what kind of food trigger this kind of pain. If there's a specific food trigger, yes, avoiding this food may help with management of pain. But again, we have to see the extent of the endometriosis. Apart from dietary changes, it is the most important thing will still be either hormonal treatment or surgeries in regards of management of this condition. Next question. If cysts keep coming back and grow bigger, what else be done other than surgery and drugs? Yes, it's a very common questions that we see and very common scenarios that we see. So that's why prevention from the first place is very important. So why do we need repeated surgeries for endometriosis? Because if we do surgery too early, then if the surgery is incomplete, of course, there's a very high risk of cysts coming back. So when we find a cyst, we have to ask ourselves, does this patient really need the surgery? So doctors need to assess, apart from the cyst, whether there's any other organs that is affected by endometriosis. So if there's only one cyst, no other organ involvement, if the patient is young, we usually try with hormone rather than doing surgery immediately. So the whole approach is also to avoid repeated surgeries, avoid impact on the ovarian reserve. So what can be done? So I think if you found endometriosis, it's good to talk to endometriosis specialists. Don't jump into surgeries immediately. Try with other options to have a complete assessment of the pelvis of the endometriosis situation. If possible, if there's no deep infiltrating endometriosis, try with hormonal therapies first. Or let's see if there's any recent plan on getting pregnant, you can try pregnancy first. So endometriosis will still recur even after hysterectomy. Is there a treatment for this? Yes, of course. So after treatment, so the indication for hysterectomy, of course, is very important. But for some patients who already have a hysterectomy and the pain is still persists, we need to check what is the reason that these patients still having pain. Is it because the endometriosis was not removed during the hysterectomy? If this is the case, then we have to see what are the organs that is involved by endometriosis. So if it is very superficial endometriosis, which the pain is, and it doesn't affect the surrounding organs, yes, there's a role of hormonal treatment to suppress the endometriosis. But again, if the endometriosis has invaded into the bowels, caused severe adhesions, invaded into the ureters, caused severe pain, then for this kind of cases, we have to do a repeated surgeries for removal of the endometriosis outside of the uterus. Can endometriosis and adenomyosis be treated with TCM, or best to avoid Chinese herbs? Over the years, I've seen patients went to TCM treatment or taking Chinese herbs. I think it really depends on where is the location of the endometriosis. It may be good for pain management. I'm sorry, I'm not a TCM doctor, and also don't know what kind of Chinese herbs will be beneficial for pain management. But again, if there's evidence of a cyst or deep infiltrating endometriosis, and if there's a physical disease there, the treatment or suppression ideally should still be with hormonal or with surgeries. TCM can be a supplement treatment, but cannot replace hormonal or surgeries for management of endometriosis. Next question, what are the chances for cancer with endometriosis and cysts? So there's a term called endometriosis-associated ovarian cancer. the risk is 2%. It mostly occurs at the age of perimenopausal or postmenopausal. So that's why even after menopause, we usually will follow up with our patients on a yearly basis to scan and also to examine the patients for any early detection of cancer. But again, the limitation is that cancer, for cancer, it's very, very difficult to diagnose in the early stage. So if by the time that we already found the cysts have cancerous looking, or if you already have symptoms of bloatiness, pain, then by the time it's very likely to be stage 3 to stage 4. But again, this addresses the importance of monitoring for patients even after menopause. And we do suggest, for the past few years, there is a lately trend that if there's a stable cyst, even after menopause, then we'll more suggest for doing surgeries for clearance in order to reduce the risk of cancer. So next question, on Visan for 2 months due to adenomyosis, on and off experiencing pelvic pain and brown staining during menses, is it normal? Yes, for Visan, it does take some time to take effects. And during this, it usually takes about 2 to 3 months to see the effects on pain suppression. And again, during this 2 to 3 months, very often 90% of patients would experiencing brownish staining or spottings. So it is common. So when for those of us who started Visan, usually I would explain to the patient before starting Visan the most likely side effects that they may encounter, and usually these side effects, for example, spottings, would disappear after 2 months. And that is also the time when the pain suppression started to show. I have hysteroscopy done 6 months ago for uterine polyps removal due to abnormal bleeding.
Dr. Mali, sorry, I'll just pause you there. So this is going to be your last question before we proceed with the launch.
Okay. Yeah, we can. I mean, for those of us still having questions, whereas in the group, we can also discuss in the group. So I think due to the time limits, I will answer the last questions. Yeah, so abnormal spotting occurred recently. Doesn't mean that there's uterine polyps formation again, or can it be due to other factors? Any action required immediately? Well, I do think usually for spottings, it may be due to many different factors. For example, it could be due to polyps, or adenomyosis itself can also cause prolonged spottings as well. So I think you can go back to the gynae doctors and have a detailed checkup and see whether there's any other factors causing the prolonged bleeding. Yeah. Thank you, everybody, for the participation and for all the questions. I think it was all very, very good questions. We hope that within the support group, we can always give support to each other. If anyone have any questions, we can always communicate on the support group. Thank you very much.
Thank you very much, Dr. Mali, for the awesome and enriching presentation. I learned a lot myself as a patient. I will be proceeding next with the launch of our website, but I am having a technical issue. To be honest, this is our first time utilizing Facebook room. There's a lot of room for improvement, most definitely. So we appreciate your kind understanding and cooperation so far. I apologize because of the noise of disruptions and stuff like that. We're still getting used to this function. I would need Dr. Mali's help. I cannot share screen at the moment. I'm not so sure why. I have emailed the launch video. Dr. Mali, would you be able to share screen and show them the launch video that is created? Dr. Mali? Dr. Mali, are you there?
Yeah. Yeah.
Yes. All right. So I emailed you the launch video. Would you be able to share screen? I'm having a technical issue with my own Facebook room. I'm not so sure why it is not reflecting the share screen. I have emailed you the first launch video as well as the thank you video. The thank you video has the redemption link for the menstrual heat. So perhaps you can share screen the first video followed by the second video. Thank you very much, doctor. So sorry. Yeah, so it's in your email.
I'm trying to
I title it. I title it as help.
I'm also having some problems. 1 minute.
Sure.
Continue.
Just see. By the way, if you are wondering, it was okay when we tried it out. When I tried it out, but somehow today it just brain fog on me somehow. It's a yeah.
It's a link.
Able to?
Not get the link. No.
No. Not possible. No. Okay, let me just try again. Try again. Possible?
If you
can, no, yes.
Share my screen and you can get me how I do it.
Okay. How about this? All right, this is embarrassing. I'm so sorry, people. Okay, never mind.
Why don't we put
I'll just say it out. Or you can also download it from the WhatsApp. I have broadcasted.
I can now. Okay.
WhatsApp web.
Now okay already. I think it's
WhatsApp web. Okay.
I think
can already.
I think. Okay. Let me just.
Or you can open your WhatsApp web and download it.
I think
we'll give it one more try.
I cannot. I think you sharing.
How about WhatsApp web?
I somehow cannot
share screen from the WhatsApp. Okay. All right. It's okay. It's okay. So this is what's going to happen since we are not able to launch it through the video. I created a nice one actually. I will be. Oh yes. That's the one.
Okay. Okay. Next time we know.
Okay. Let's play that. Let's play that. Okay, the launch of our website. Let's go.
No sound.
All right, so basically the website is endosupport.sg. All right. And we are also officializing a campaign known as the White campaign. Yeah, it's a bit lagging. Okay, Dr. Mali, it's all right. I think I'll just explain to them lah. You can just close it. It's okay. Thank you, Dr. Mali. All right, so I'll just take over from here. So sorry, everyone. Okay, so the official website is endosupport.sg. So what I will be doing is I will just post the video in our support group instead. So the idea of having this website is we actually put a lot of thought in it. The idea is to make it simple, accessible, and user-friendly. That even someone who might have lived in a different world and doesn't know that woman has womb would be able to get it. All right. So we are using layman terms. You are looking at things like what is endometriosis, the diagnosis, the treatments, the symptoms, and all these are actually stringently vetted by endometriosis expert herself, Dr. Mali. And we hope that with this website, it make it easier for you to explain to your loved ones or whoever that want to understand the things better. So in the endosupport.sg, there is a research tab itself. These are all carefully collated by Dr. Mali, and it will be updated every now and then. So you will be looking at current medical researches, discoveries, tests, experiments, both local and international. And then where there's also a patient stories tab, and this tab will soon be filled, hopefully, with all your stories and write-ups. So please send it to me at iamnamira.e@gmail.com. You may think that it doesn't mean much, but trust me, people do read, and your write-up could be the reason a fellow warrior or supporter choose to get by despite has given up earlier. So your stories can make a difference. So do email it to me at iamnamira.e@gmail.com. Now the next part of this website launch is also a campaign known as What If campaign. It is actually a campaign whereby you utilize a What If campaign frame in Facebook. So you just have to search for hashtag What If, and then utilize the frame for a month. And also in the description, you just write down your what if statement, like what if I chose to see the doctor earlier, I would have been able to receive a proper treatment earlier or sooner, something like that. The idea is the objective is to create a ripple effect so that many of us would have a conversation starter on endometriosis. Okay, as for the redemption, there is a redemption link for the menstrual heat. I apologize that this happened. I will be providing the link in the Singapore support group. In the Singapore support group as well. So do get yourself a redeemable menstrual heat pad. And to sum it up, I would also like to say thank you to the official sponsor for making this happen, which is the first one, Bayer. The second one would be Blood. Blood is the company who created menstrual heat. And we are thankful that they have been supporting us with and partnering with us in making this website happen. And yeah, I think that's about it. I don't want to take so much of your time, especially in this beautiful Saturday afternoon. Thank you everyone for making this historical moment, for joining us for this historical moment. I appreciate your time, your support, and I hope that today's session encourages you as well to keep on creating endometriosis awareness, especially now that it is the Endometriosis Awareness Month. I wish you, wishing you all in good health, with love and joy. Thank you everybody. Have a lovely Saturday. Take care and be well. Bye-bye.
Thank you, everybody. Take care.